Good morning. Our guest speaker today is Dr. Devin Kansagara, who is director of the Evidence-Based Synthesis Program based at the Portland VA and an associate professor in the Department of Internal Medicine, as well as the Department of Medical Informatics and Clinical Epidemiology at OHSU. Dr. Kansagara did his internal medicine residency at Yale, where he then was chief resident for an additional year before coming to Portland to do a 2-year health services research fellowship at OHSU, and then he joined the faculty in 2007. He's a reviewer for numerous journals, including the Annals, JAMA, and JAMA Internal Medicine. He is a panel member of technical expert panel member for AHRQ, and he's a member of the National ACP Clinical Guidelines Committee ever since 2014. In his relatively short career, he's already won numerous awards. In 2014, a Clinician Investigator Award from the Northwest Chapter of SGIM, Humanism Award from OHSU, and several teaching awards from OHSU. And in 2012, he was awarded the prestigious Outstanding Young Physician Award from the Oregon ACP. He already has over 40 publications to his credit. His focus in terms of scholarly activity has been on transitions in care, as well as comparative effectiveness, and 6 of these publications have actually been published in the Annals of Internal Medicine, and he's first author on 4 of them. And this morning he's going to talk to us about whether performance metrics are threatening the health of our healthcare system. Devin?
Thanks. Okay, good morning. Thanks for coming and thanks for having me. So this is kind of a silly question to ask, and so I'll warn you I don't have an answer to this question, but we'll at least have some fodder for debate. So just 3 days ago in the Sunday Times, Bob Wachter wrote an opinion piece highlighting many of the issues we'll talk about in more detail this morning. Essentially, that performance metrics made sense in a historical context, but have been pushed much further than they should be, outstripping their potential benefits and exacerbating harms. He additionally points out the clear parallels to the very public debates about testing, accountability, and public education. I first became aware of the emotion and consternation engendered by performance metrics almost accidentally. We were one of 5 sites nationally charged with evaluating the implementation of the patient-centered medical home in the VA. We had done a large qualitative study about medical home in general, but didn't ask about metrics specifically. In looking at the codes developed from the many transcripts, we were surprised to find how often performance metrics were spontaneously raised as an issue, even though we didn't ask specifically about them. They seemed a touchstone and not often a favorable one. There was, in fact, so much related to performance metrics that we decided to write a paper focused only on these comments. In this paper, we wrote that primary care staff perceived performance metrics led to delivery changes that weren't always aligned with medical home principles, didn't accurately reflect patient priorities, represented an opportunity cost, were imposed with little communication or transparency, and were not well adapted to team-based care. The very vocal concerns we found in our own work about metrics are especially concerning when considered in the context of physicians' dissatisfaction and burnout. In this national study, rates of physician burnout were high, much higher than in a matched sample of working U.S. adults. Almost 50% of physicians sampled in this survey scored high on the burnout scale. Interestingly, the accompanying editorial was written by a prominent behavioral economist who cited loss of autonomy as one of the major contributors to physician disillusionment with their work. He says, "We view the practice of medicine as a production function, a sort of fixing people production line." He goes on to say that medicine should be viewed as a research and development activity. In a research and development practice, it is assumed that providers need time to think and reflect, and that they need the flexibility to control their time, take different paths, and adjust as they make changes. An older study from the Community Tracking Survey, in fact, found clinical autonomy was one of the biggest contributors to variation in physician satisfaction. But before we throw the baby out with the bathwater, it may be useful to briefly recognize the evolution of measurement and standards in healthcare. I think it really helps highlight how measurement is at the heart of what's very good about our modern healthcare system, and also demonstrates that the complexity of our performance measurement system now may obscure what worked in the past. So in the Crimean War of the 1850s, Russia lost, but quality measurement won. The British were part of the winning allegiance and dispatched a team of nurses, including Florence Nightingale, pictured here, to attend to wounded soldiers in Turkey. Influenced by the findings of Semmelweis that hand washing led to a reduction of disease transmission on obstetrical units, she required beds to be spaced 3 feet apart, removed horses from the hospital basement, and required disinfection of latrines. As you can see in these coxcomb displays, and these are the progenitors of the modern-day pie chart, the mortality rate from diarrheal illness dropped dramatically within 6 months of her arrival. So that this is in 1854, and she came midway through that year. The gray are deaths from diarrheal illness, and she instituted her changes, and we saw a marked reduction in deaths from diarrheal illness. In 1918, the surgeon Ernest Codman became one of the first to publicly advocate that hospitals systematically collect data on long-term outcomes and designate whether poor outcomes were related to provider care, organizational characteristics, patient comorbidities, or social issues. He stated, quote, "This will give a definite basis on which to make efforts at improvement." Fast forward a little bit, Jack Wenberg's classic paper, which led to the creation of the Dartmouth Atlas, a table of which is shown here, showed that there were dramatic variations in the number of surgical procedures performed in different rural communities in Vermont. The variation was not explained by differences in case mix or other population characteristics. In the early 90s, there was a marked change in the way quality measurement was done in the country. Earlier efforts had really focused on small-scale, substandard practice, and there was a move to standardize quality measurement to improve standard practice across systems. And there were some early successes. 20 years ago, only about half of acute myocardial infarction patients were discharged on beta blockers and about 2/3 on aspirin. And one big project, the Cooperative Cardiovascular Project, sought to improve these rates through quality measurement and reporting. And they saw substantial improvements in aspirin and beta blocker prescription, and they saw reductions in 30-day and 1-year mortality rates in the pilot states. Of note, this program was not associated with the financial rewards or penalties. So one of the things I want to point out is that this early work was fairly focused and instrumental. They gathered data, they reflected on data, they made some improvements, and so on went the cycle. In the last 10 or 15 years, there have been increasing alarm, however, about the quality of care delivered in the country. So this study is one example of a clarion call that our healthcare system was widely underperforming. This is an extremely widely cited article by Elizabeth McGlynn and colleagues, who found that almost 50% of patients did not receive recommended preventive, acute, or chronic care. More recently, over the last decade, the number of pay-for-performance reporting measures in both inpatient and outpatient settings has grown rapidly. I would argue also that not only are there more metrics, but the ways in which metrics impact frontline clinicians has also changed because of electronic health records through functionalities such as electronic clinical reminders. So more metrics and perhaps more burden from the metrics. So what are performance metrics? Well, very simply put, they're just data and motivation comes in one of two flavors. It's either financial rewards or penalties, or embarrassment, which is basically public reporting. So I won't spend much time talking about public reporting in this talk, but anybody who's driven down a highway knows about the existence of public reporting. There are billboards everywhere, and it seems like pretty much every hospital in the country is top 100 of something or other. You can compare hospitals against one another on hospitalcompare.gov, and you can get nice certificates with lots of stars on them. So does public reporting work? There are two systematic reviews published in 2011, which looked at a slightly different set of literature. The Cochrane review found no consistent evidence that public reporting changed either consumer behavior or improved care. And then the second review, which actually looked at a broader set of studies, found that it did improve process and quality measures, especially in low-performing long-term care facilities, but there was no evidence that it changed consumer choice or behavior. Okay, so now I'll really focus on pay-for-performance programs. Does it work? So I'll spend a few minutes here talking about the evidence. So we, last year, conducted a systematic review for the VA, looking at the literature, both in this country and outside this country, in countries like the UK, to understand whether or not pay-for-performance programs worked and which factors contributed to them working better or not. So we found quite a number of studies. Many have been done in the ambulatory care setting and fewer in hospital settings. And QOF stands for Quality and Outcomes Framework, which is the large UK project, which I'll describe in more detail in a moment. So what did this all show? To boil it down, basically, we found that pay-for-performance programs often improve processes of care that are targeted by the intervention, especially in practice with low baseline levels of performance. But these were often short-term effects. The effects plateaued. They were relatively small effect sizes, and the results were inconsistent from study to study. There was little good quality evidence in the US on the association between pay-for-performance programs and health outcome effects. And in the UK, there were some studies showing unsustained small effects. So this is a hard literature to summarize, and I can't go through it all, but I'll just highlight two big programs, one in the UK and one in the US. So in the UK, they basically overhauled their entire primary care health system through what's called the Quality and Outcomes Framework. And in this, frontline primary care providers are eligible to earn up to about 1,000 points in different areas: clinical care, practice organization, patient experience. And it's a lot of money. It can be up to $77,000 a physician and was 20% of the government family practice budget. Went into effect in 2004. Of note, they had a lot of patient exclusion criteria. So clinicians could exclude patients from the metrics. And these were some of the criteria they could use to exclude patients from the metrics, including the last one: the treatment is clinically inappropriate. So they had, physicians had a fairly broad umbrella to exclude patients. So what did they find? Well, the outcomes have not been that impressive. The graph on the left shows performance on aggregate scores of mainly process of care and intermediate health outcomes for common chronic conditions: coronary heart disease, asthma, diabetes. So the QOF program started here, and you can see that improvement had already begun well before then. And basically, the QOF program just continued the trend, and then improvements leveled off. The graph to the right shows the impact on patient experience, so which essentially stayed flat before and after the QOF. Continuity of care measures, communication with physicians, the ability to get an appointment within 48 hours. Okay, how about the US? Well, one of the big programs in the US has been the Premier Hospital Quality Improvement Demonstration Project. And it provided data on 33 measures, which were mostly process of care measures. And they also included mortality indicators for MI and coronary artery bypass graft patients. In this program, high-performing hospitals were eligible for a bonus, and low-performing hospitals were eligible for a penalty. So this is a graph of the overall performance score, which is a composite of process of care measures for CHF, MI, and pneumonia. And they saw that performance was modestly better in the HQID group for the first several years, but then the difference became non-significant by 2008. So the light blue line is the HQID program, and the red line is the control group. They also looked at long-term mortality effects. So there are about 250 intervention hospitals, over 3,000 control hospitals, and they controlled for potential confounders and looked at 30-day mortality for MI, CHF, cabbage, and pneumonia, and found basically no difference. So there are two lines here, but they're superimposed on one another, so you can't really see them. The red is the control, the blue is the intervention. This is where the HQID program started, and so you can see the lines are essentially identical, and there were mortality reductions in both groups of hospitals. Okay, so we talked a little bit about the potential benefits. What about the harms or unintended consequences? Well, one is obviously gaming. And gaming is hard to measure. Gaming is basically teaching to the test, or in more nefarious terms, cheating. So it's hard to find studies of gaming. And of course, even though there's little published literature examining the extent of the problem, it clearly happens. So anybody who's listened to the news over the last 2 years knows this example. Several years ago, the VA nationally introduced a 14-day access performance measure. It was not treated as an aspirational goal, but really was treated as a mandate. In 2014, news broke that leaders at several dozen VA facilities were falsifying and manipulating wait time data. Obviously, these acts were unprofessional. Nobody would argue that. Nevertheless, simple condemnation without an exploration of root causes does not set the stage for reform. Ken Kaiser, who was the Undersecretary for Health at the VA in the 90s, and one of the architects of the widely lauded improvements in quality over this period of time in the VA, wrote an editorial in the New England Journal reflecting on the wait time fiasco. He said, quote, "VA leadership created a toxic milieu when they imposed an unrealistic performance standard and placed high priority on meeting it in face of difficult challenges, namely understaffing, and expressing a no excuses attitude." He goes on to compare earlier performance improvement program in the VA, which focused on just 24 measures, to the current situation in which there are hundreds of measures with varying degrees of clinical salience. He says, quote, "The use of hundreds of measures for judging performance not only encourages gaming, but also precludes focusing on or even knowing what's truly important." So another concern is attention shift, or another way of thinking about it is opportunity cost. You spend a lot of time focusing on incentivized measures, and what happens to unincentivized measures. There's only so much time a physician has. We did not find many studies that looked at attention shift. This is one study that did. So this is a study from the QUAF program, that British program, and they basically found that incentivized measures improved more than would have been anticipated based on pre-intervention trends. So if you look at the slope of improvement before the program went into place, the incentivized measures, the grade of the slope increased more than the pre-intervention slope. Whereas in the non-incentivized measures, the slope grade decreased. So it was negative in non-incentivized measures. So small amount of evidence that attention shift may occur, but there's not a ton of studies. I think there's now we're kind of moving away from where the studies really are, at least in our review, and moving on to what I think are, I'll call structural issues with performance metrics. And these are issues that I think will always be inherent to performance measures and strongly inform the balance of benefit and harm for performance measures. And this is really where you get into how you implement the program, and we'll get to that at the end. So the first thing I want to talk about is evidence and metrics. So metrics should ideally be based on a very strong foundation of evidence, but sometimes they're not. And one of the reasons is that evidence is just fickle, and that's just a property of evidence. Much of what we initially believe is right is ultimately not supported by accumulating evidence, and there are an increasing number of studies looking at this. Vinay Prasad, who just joined our faculty, looked at this. He looked at all articles published in the New England Journal of Medicine from 2000 to 2010 and found that 40% of studies found evidence that was different or challenged accepted standards of care. And John Ioannidis has done work that's been widely cited that shows something similar. I think the other issue is that metrics may push evidence beyond its limits. In other words, are we jumping the shark? A good thing can turn bad if you push it too far, as the creators of Happy Days found in this episode in which Fonzie was made to jump over a shark on water skis. The 2003 IDSA pneumonia guidelines recommended initiation of antibiotics within 4 hours of hospitalization. This was based on a large retrospective cohort of Medicare patients, which found that patients who received antibiotics within 4 hours of presentation had lower mortality and length of stay than those receiving it after 4 hours. But the finding of lower mortality was of small magnitude, and they actually found a slightly larger impact when using an 8-hour threshold. Nevertheless, this was translated into performance measures linked to financial incentives by many third-party payers, including CMS. So this study compared pneumonia treatment treated at a large teaching hospital before and after the publication of the guidelines, and found that there was more antibiotic utilization, but fewer people were diagnosed, had a final diagnosis of pneumonia, and there was no difference in mortality rates. So in other words, after the guidelines went into place, there was pressure to prescribe more antibiotics, and the proportion of people who got antibiotics who actually had pneumonia was smaller, and there were no difference in mortality outcomes over this period of time. One of the issues is that I think it's all too tempting to push to increase the numbers. The logic of metrics is to push numbers higher. And I've spoken to non-clinician quality program officers to whom it just doesn't always occur that pushing the target higher is not necessarily a good thing. So one VA study examined overtreatment of blood pressure in diabetic patients. They found that facilities that performed best in proportion of patients meeting targets also had higher rates of potential overtreatment. And one of the problems is that once treatment is started, it often doesn't get stopped. So this was another VA study that looked at treatment de-intensification. And they looked at over 200,000 patients over the age of 70. And overall, only about 27% of patients with very low blood pressures or hemoglobin A1Cs on treatment had medication decreased or discontinued. And these bar graphs also show that low life expectancy did not correlate with treatment de-intensification. So this is percent of patients that had de-intensification, and the different colored bars represent different life expectancies. So the white bar is less than 5 years, and you can see there's really not much substantial difference in de-intensification rates, whether or not your life expectancy was low or not limited. Another issue is that metrics are not tailored. They're blunt instruments, one-size-fits-all clothes. They have the potential to take evidence that at best comes from trials with often narrowly defined patient populations, and even when treatment or screening is well supported by trials, it can look funny when forced onto the wrong patients. Cynthia Boyd and colleagues found that practice guidelines rarely acknowledge treatment of a chronic condition in the context of multiple other chronic conditions, or in other words, multimorbidity. They applied recommendations to a hypothetical 79-year-old woman with several chronic conditions and found the list of patient and clinician responsibilities to be lengthy. This is not meant to be read. It's just meant to show that there's a lot of things that one must do to accomplish all of recommended care, and that the daily schedule for the patient is quite cumbersome. So switching gears and getting to what I think is really part of the heart of the matter is talking about intrinsic versus extrinsic motivation. Intrinsic motivation refers to behavior that's inspired by internal rewards, doing something because one thinks it's the right thing to do. And extrinsic motivation refers to some external tangible reward or penalty. In many ways, I think this is the most deeply seated issue at the heart of the debate about performance metrics. I believe this is a big part of the emotion that imbues discussions of pay-for-performance programs, and one of the reasons why perceived loss of autonomy was found to be such a big driver of career dissatisfaction and burnout. So I learned in the New York Times article I earlier referenced that this was the response of Avitas Donabedian, who's one of the pioneers of the modern-day quality measurement movement, when asked about his thoughts about quality just before he died. And many providers believe that the secret of quality really is indeed love of one's patient, love of professionalism, love of the amalgam of art and science that is medicine, and they resent external forces trying to fuel what should be a self-fulfilling mission. I think policymakers need to understand this emotion in designing sensible programs that make measurement a part of that intrinsic motivation and not an enemy to it. In other words, get back to the simplicity of the concept that Codman and others had promulgated many decades ago. So I'm just going to switch gears a little bit and delve into the evidence, the social science evidence looking at extrinsic versus intrinsic motivation. And there's a fairly large set of thought-provoking studies that suggest that incentives can squash intrinsic motivation in the right circumstances. Of note, there's no literature examining this in healthcare. So this is mostly just for interest. So one thing to note is that if this occurs, this mainly only occurs for interesting activities. So things like shared decision-making, diagnostic workups, difficult patient discussions are complex, interesting activities that don't need to be externally rewarded. On the other hand, there are things that we must do that have no attached intrinsic motivation. My own personal example is the completion of a plethora of seemingly meaningless web-based training modules. I wouldn't do them if loss of computer privileges was not threatened. Some studies have shown people volunteer less after payment was introduced. For instance, a study using data from a Swiss workforce survey found people who received small payments actually volunteered less than those who received no compensation. When Swiss citizens were asked their opinion about locating a waste repository near their town, 51% were willing, but this number fell to 25% among those offered a monetary incentive to do so. And financial incentives can have a long-term counterproductive effect. So this study hit close to home and I thought was pretty interesting. This is a study of 10 daycare centers in the Israeli city of Haifa conducted over 20 weeks. They measured the average number of late arrivals per week. In week 4, investigators introduced a fine at half the sites and no fine at the others. And they actually found that the group with the fine had a doubling of the number of late arrivals, whereas the group with no fine, their late arrivals stayed the same. And in about week 16, they got rid of the fine, and the intervention group still had late arrivals. So both the fact that the fines made late arrivals go up is interesting, and also the fact that the baseline rate of late arrivals was remarkably high. About 10 out of daycare center with about 35 kids, which was amazing to me. Okay, so switching gears again, despite all the potential negatives we've just discussed, it's worth remembering that our past pre-measurement era was not so rosy. And I think hospital readmissions are an interesting case study in how challenging the debate over metrics can be. So as many of you know, back in 2013, CMS began levying a penalty for hospitals with high readmission rates. And that there would be a penalty was known back in 2010. And the amount that hospitals could get penalized could be substantial, up to several $1 million annually. And there was also public reporting as part of this hospital readmission reduction program. There had been many criticisms about the policy. One is that the measure itself is flawed. Risk standardization models that are the base for comparing readmission metrics don't work very well. The measures are not reliable, and there's a lot of regression to the mean. The 30-day cut point that's used is arbitrary and not clinically supported. Maybe we're measuring the wrong thing. The preventability of readmissions is unclear, perhaps as low as 25%. Is it really a measure of hospital quality? There have been studies looking at whether or not hospitals with greater adherence to recommended processes of care have lower readmission rates, and the two things don't necessarily correlate with one another. And there's also concern that these focus on hospitals rather than communities. Perhaps one of the most damning issues with the readmission reduction program is the potential to exacerbate disparities. So this study looked at the hospitals that were most at risk for receiving penalties, and they were those in the lowest quartile of median county income with a risk-adjusted odds ratio of almost 3, and those with the lowest nurse-to-census ratio, the odds ratio of 2. And so these were obviously the hospitals that needed the money the most, and they would be most at risk for getting penalized. On the other hand, this is a table that shows how quickly transitional care improvement programs have spread in the country. So back in 2007, not that long ago, these are all names of either different transitional care programs or states that have adopted transitional care improvement efforts. And there's also almost nothing being done back in 2007. And by 2012, there were national spread of lots of programs. All of these efforts may be paying off modestly. Just last year, there was, looking at Medicare data, there was a modest reduction in readmission rates. They also showed a little bit of evidence of gaming. So the version of gaming for readmissions is observation stays. So an increase in the coding of hospitalization as observation stays, since they don't get counted as an admission. So there's a modest increase, but this didn't account for the drop in readmission rates. So this article looked at hospital readmissions in the Medicare population and found they were common and costly. And the author said, even a small decrease in the readmission rate could result in substantial savings. The prospective payment legislation, however, creates economic incentives that could increase readmission rates. Attempts to develop hospital readmission profiles will need to control for hospital and patient characteristics that are correlated with the likelihood of readmission. And even though it sounds like this was published in the last 5 to 10 years, this was actually published back in 1984. It didn't get much traction. It's only been cited under 300 times in the last 20 years. So I would argue, even though there's a ton of problems with the readmission program, nobody was doing anything about transitions of care, even though we knew there were issues dating back many, many years ago. And it seems common sense now that we should do things to improve the quality of discharge, that we should support patients in the post-hospital period, and so on and so forth. And I do believe that the threat of penalties had an impact. In our own work designing a transitional care program for underserved patients at OHSU, I can say just anecdotally that the willingness of the administrators to work with us, they're extremely willing and really good partners. And I think part of the reason was they knew that these penalties were coming. So just reviewing some of the pros and cons of metrics. Some of the pros include that there is some evidence that they improve some processes of care. On the other hand, there's little evidence they improve health outcomes. As we just pointed out with readmissions, I think they can serve a purpose in spotlighting areas of neglect. However, they're also expensive and time-consuming. I would argue that the alternative is untenable, right? You can't just get rid of metrics altogether. We reviewed some of the history, and to think that you'd go back to a system where you didn't measure anything or hold people accountable is simply untenable. But on the other hand, we have to be careful because there are potential unintended consequences. Metrics can be a powerful, if blunt, tool for disseminating evidence, but they can also become obsolete or dangerous with shifting or misapplied evidence. They have the potential to amplify intrinsic motivation, but they also have the potential to impede intrinsic motivation. So how do you capture more of the pros than the cons? Well, one of the things we were asked to do in our report was to look at some of the implementation factors associated with improving the balance of benefits and harms in programs. And ultimately, performance metrics don't realize benefit or cause harm in a vacuum. The devil is very much in the details. We outlined a few fairly common sense things to consider when implementing a performance metric program. And these are based on a combination of the empirical evidence from the literature and expert opinion. As part of our report, we conducted hour-long interviews with 14 experts on pay-for-performance program research who each spent many years working in this area. And we found their insight invaluable, since often the nuances of this complex health system intervention literature is not represented in a 3,000-word journal article. So first, measures should be transparently evidence-based and be viewed as clinically important. Programs should engage providers from the outset. Now, even though this sounds like common sense, it's not always done. And even if you have a metric that's evidence-based, I think what evidence-based means can differ, and I think you really do need to convince providers that this is the right thing to do. Measures that target process of care or clinical outcomes may inspire more positive change than programs that use measures targeted to efficiency or productivity. So this is based on both comments from the experts, but also a few studies that looked at the impact of different types of metrics on physician behaviors and attitudes. Programs should have the capacity to change over time in response to ongoing measurement of data and provider input. For example, the UK program, the QUAF program, is evaluated annually and has undergone numerous adjustments since its inception. Perhaps the most dramatic of which is the reduction in the number of incentives. So they started with 140 incentives, and over time they realized how unwieldy it really was, how much dissatisfaction there was, and how many unintended consequences there were. And they lowered that to about 80 now. Programs should target areas of poor performance and consider de-emphasizing areas that have achieved high performance. So findings from studies of both the UK program and also the VA and interviews with our key informants suggest that improvements associated with measures achieving high performance can be sustained even after the measures have been de-incentivized. So consistent evaluation of the performance of adjustments to incentivize measures will allow institutions to shift focus and attention to the areas of greatest need for improvement. Lastly, metrics should ideally spur substantive changes in the structure of healthcare delivery and be fewer in number. So I think given the lack of clear evidence of benefit, the potential harms, and the associated time, effort, and cost of performance metric programs, they should be strategically chosen as platforms for broader change in the structure of healthcare delivery. And I think this has not been adequately addressed in the literature. So people often look at metrics as improving the thing that they're measuring, but I would argue if they're used correctly and used as part of a broader quality improvement program, that they could be used as kind of a canary in a coal mine to detect broader systems issues and fix the system in more structural ways. So I think that the pendulum is starting to swing back towards a more reasonable place, but it needs to swing more quickly before more physicians feel at odds with the system rather than part of fixing it. This article was in the New York Times just a week ago, and it reports efforts at Peace Health in Eugene for the hospitalists there to unionize. And most of the article was about performance measurement. Smaller hospitals and health systems don't have the infrastructure to keep up with all that's required for reporting of the many existing performance metrics. And this hospital is going to outsource this work and basically create a new set of bosses for the hospitalists there. And the article goes on to say, the way the hospital has interpreted the mandate, meaning to achieve measures, has left them feeling demoralized. If you talk to them for long enough, you get the distinct feeling it is not just their jobs that hang in the balance, but the loss of something much less tangible, the ability of doctors everywhere to exercise their professional judgment. So to close, I think we should help steer the ship and don't get steered by it. Performance metrics are likely here to stay and will continue to be imperfect. However, the conversation is increasingly recognizing the need to implement them in ways that minimize unintended consequences while preserving benefits. There's so much momentum, infrastructure, and money behind the measurement industry that metrics will fill open spaces. But it's up to healthcare providers to get involved in the design and implementation of metrics locally and help steer the ship to the right destination and not run it aground. Thanks very much. Okay. Yeah.
So that was really great, and I completely agree with your ending statement, but the question is, how do you do that? I mean, it's great if you're in an institution where your administration recognizes you, but that's certainly not universally true. And do we need a more universal mandate to allow physicians to be in charge? I mean, I read the New York Times article. My impression is that really physicians feel like they don't have a voice at all. There's an extreme reaction going to unions. So how does the average regular clinician get involved in influencing metrics, even if they want to?
Yeah, no,
If your administration doesn't care.
Yeah, so the question is, and it's a great question, how do you actually do it? It's great to say that physicians should get involved and don't get steered by things and be the driver and not the driven. But how do you actually do that? It's a great question. I don't know that I have a simple answer, but I think it's a variety of things. So I think there are examples of physicians being involved in the design and implementation of metrics. So for instance, in the VA, I mean, the problems with the measurement, the way measurements have gone in the VA are well known. And they're actually starting to make some changes. And part of it is from writing reports and feeding back the data to those in charge, and there's good physicians in charge now, sitting on the committees that are coming up with new metrics and so on and so forth. And I don't think that it's necessarily the case that every physician should be involved, because obviously not everybody's going to have time to do that. But I would argue that there are opportunities to get involved on committees on choosing metrics. My understanding is that, at least for some metrics here at Providence, there is provider input into what measures are instituted. I'd also say to trainees that, that as they move into their careers, they may be in positions of doing some healthcare administration and may be the ones imposing some of these metrics. And so some of this is trying to pay attention to what works and what doesn't work.
Yeah. In the last 45 or 50 years since I've been in medicine, I've noticed in the last 10 or 15, more and more I hear the statement, he who has the money makes the rules. Maybe the wrong people are making the rules. Maybe the wrong people have the money. I don't know. Yeah. But I agree. I'd like to see doctors more involved in it instead of lessons.
Yeah. So and so the comment was that over a long period of time, it's typically the people that have the money that make the decisions, and I think that's true. I mean, I think there's some changes with the ACA that are meant to address this issue. So the accountable care organization structure, to be counted as an accountable care organization, you have to have physicians in leadership, and part of what the leadership does is to decide which sets of measures you're going to use to establish benchmarks, which then will determine, getting money back as rewards. So, and I think it's, I can't remember the percentage, but it's in the legislation that they have to have physicians on the panel. So, and it's in part to get at these last two comments, to have more representation. So I think laws like this are part of the issue, and I think also more vocal criticism, like was done in the editorial I pointed out earlier, is part of it as well. Any other questions?
Yeah. So how are the metrics looking at, are they considering what your patient population is? I mean, I guess I don't really know how to ask the question, but if you tell me you're only going to pay me for my performance, I'm going to choose a patient population that's not, underserved or underinsured or in
Right.
that will be more successful. Because I can't control what my patients do when they go home.
Yeah.
So how do the metrics actually account for that?
Yeah, so that's a great question. The question is, how do you prevent basically what's called risk selection? So one of the, and for time's sake, I didn't go into this, but one of the potential unintended consequences of measurement programs is exactly what you brought up, which is called risk selection. So at the extreme, one could say, well, you're just going to choose the people who are healthiest. And so they've looked at this. So there was a study looking at rates of exception reporting in the UK program, the Quality and Outcomes Framework. The exception reporting, I showed that slide that said they had a lot of leeway. Physicians could basically exclude patients from the measurement if they thought treatment was clinically inappropriate, which is a broad enough thing that you can include a lot of patients there. But they found the rate of exception reporting to be much lower than people had feared, only about 5%. So in practice, at least when physicians were given leeway, it hasn't seemed to have happened. There's also concern, people have brought this up as an issue around the readmissions thing. Well, I'm just not gonna, we're gonna send the patient down the street to some other hospital. And I think it is a concern. I don't think it's been borne out in the literature. The same concerns came up when DRG payment structures were introduced a few decades ago, and they didn't pan out.
Has there been any information on physician reaction to the patient who is always a metric outlier and never will be a metric succeeded case? Do people try to move them to a different practice? How do they feel about the patient who is non-compliant, who hemoglobin A1C is always 10% and blah, blah, blah?
Yeah, that's a great question. So what do you do with the outliers? What do you do with the patients that you just can't get to goal? And certainly we all have those patients. So I'll say, I mentioned our earlier qualitative study where we interviewed a bunch of folks in VA, frontline providers, physicians, nurses, front desk staff, and so on and so forth. And everybody had comments similar to that. There's just some patients whom, this is just not the right goal for them, or no matter what I do. And I think there is some frustration. And I think the way to deal with that mechanically from the measurement issue is that the goal should never be 100%. I can't think of many things. There may be a few examples, truly preventable things, central line bloodstream infections and so on and so forth, that might be so well understood and so focused that you can get to high numbers. But I think most of the stuff we deal with in primary care practice, the goal should never be 100% of patients. It should be much less. The problem is there's no evidence. It's hard to take the evidence base and figure out what that number should be. It should be 60% of patients, should be 70% of patients, 80% of patients. So the reason the number should be less is because the points you just made, they're going to be outliers, and it may be appropriate. Not everybody should have the same goal.
What about potentially conflicting metrics? So you gave the example of early antibiotics. Now there's the push towards antimicrobial stewardship and trying to limit the use of antibiotics, and those regulations will be coming up in the next few years. How are we going to reconcile that?
Yeah, that's a great question. So how do you deal with potentially conflicting metrics? So one of the slides I had added in there and took out was a graphic we had made for another paper we're writing, which looked at the way metrics can be imposed. And in many cases, they can be conflicting, and in the ideal scenario, they're complementary to one another. In our VA study, we found lots of examples of conflicting metrics. So the one that kept coming up is that there's both a mandate to get patients in to be seen when they want to be seen, and also push to increase the number of non-face-to-face visits. And so those seemed like they're running in different directions, right? And so I think the way to fix this is that I think part of the problem certainly in the VA has been that there's not that measures can come in from different people. So there can be a group that's particularly interested in foot amputations at the time, and there's a metric that comes up with that. And there's another group that wants to do this. And so there's no body that's taking this collection of metrics and saying, how do these work with one another? So I think there needs to be a group that basically at each organization is responsible for vetting a set of metrics. Metrics are blunt instruments. They're powerful tools. They should have a really high threshold for being implemented. And I think there should be a single body that does just that and says when they're at loggerheads to take one out or.
Other questions? Gentlemen, thank you for a terrific way around.
Oh, sorry, forgot. Peter?